Welcome back. Video number 13, case number 2, Ivus in Anomalous CX. Anomalous RETROAORTIC CX from RCA or right coronary sinus. Is it a benign course? Is the term potentially malignant applicable? When to suspect and how to avoid? Male patient, non-ST elevation myocardial infarction with mild chest pain. Previous CT 7 months ago showed normal coronaries with anomalous CX from the right coronary sinus. Coronary angiography showed normal LED and mild atherosclerotic changes in the RCA. CX was codominant with separate origin from the right coronary sinus with distal 2 successive subtotal lesions with no early OM branches. Although it is small in diameter, yet it is a precious branch. Also, there is a proximal focal non-significant lesion with haziness, no evidence of slit-like ostium or intramural course. This was documented in the previous CT. PTCA was done to the CX lesions after semi-compliant and non-compliant balloon dilatations. A drug-coated balloon 40 millimeter length was dilated with acceptable post-PTCA results. What about this lesion and the haziness? This proximal lesion needed evaluation. Is there any dynamic compression? 2 days later, Ivus study was performed to evaluate the lesion or compression in the retroaortic segment. The segment distal to the dilated segment showed an area of 2.5 millimeter with plaque burden about 30%. While at the site of the drug-coated balloon dilatation, the cross-section area was about 5 millimeter square, at the largest plaque burden 56%. At the site of the angiographic lesion proximally, the cross-section area was about 5.7 millimeter square with plaque burden only about 50%, with absent ulcers or thrombi. The angiographic haziness disappeared at the day of the Ivus run. Yet, dynamic compression appeared just proximal to this lesion. The compression was between 6 to 9 o'clock in this proximal retroaortic segment. This compression caused some degree of dynamic decrease in the cross-section area of the CX lumen. Dynamic compression was from the aortic sinus, most probably the posterior sinus. The compression is in diastole. Notice the closure of the aortic valve with compression. So the term dynamic compression, not systolic, is the correct term. Since the cross-section area of the CX is mildly decreased with insignificant plaque burden, nor ulcer, nor annular compression or calcification, medical treatment is advised. This includes beta blockers. And these are the topics to be discussed regarding anomalous CX, course, cases, and Ivus in anomalous CX. Regarding the course, the anomalous CX green line passes retroaortic, especially the posterior sinus, mainly retrosinus or retroannulus, anterior to the mitral and tricuspid annulus, and related atrial chambers or interatrial septum. So, any pathology or procedure in these structures may cause compression, dynamic or permanent, on the retroaortic segment. This course can be seen angiographically. The non-coronary sinus, posterior sinus, may not appear except faint and late, and at a lower level than the other sinuses. In the lateral view, the CX is in direct contact with the posterior border of the aorta non-coronary sinus. Dynamic compression of the distal part of the retroaortic segment may appear, and this may cause ischemia. Many factors may affect the degree of compression. The level, is it mainly retrosinus or retroannular? Is it anterior to the mitral and tricuspid annulus or related atrium or interatrial septum? The distance in between, presence of calcium. There are 3 specific lines in the aortic root: sinotubular junction, the anatomical VA junction between the ventricle and the aorta, annulus, which is the basal attachments of the aortic valve leaflets. The retroaortic course could be mainly retrosinus, yellow arrow, or retroannular red arrow, which is virtual and not a straight line, and could be behind the cusp attachment itself or behind the interleaflet triangle. So not all of the retroannular course is behind the firm basal leaflet attachment. Also, the retroannular course may be calcific, and this adds to the compression. In the literature, there are many cases in which the retroaortic segment is compressed. Regarding TAVI, aortic valve implantation may cause compression on the anomalous course of the CX red circle due to close proximity to the aortic valve. In this 86-year-old patient, pre-procedural wire of the CX was done. After supine valve implantation, the artery was compressed. PCI was done after failure of nitrates to dilate the lesion. In addition to a wire, a protective guide liner and undeployed stent in the CX was done in this case. After valve deployment, the CX was normal and the PCI system was removed. It was rather a retrosinus course, not a retroannular course. In this case, CT was very helpful. There was annular calcium in contact with the retroaortic segment, so a protective wire in the CX was done. Due to appearance of haziness and due to fear of plaque rupture in the same area, a stent was deployed. Valve pre-dilatation is a good option. In this case, after dilatation, there was no CX filling. So the plan changed from balloon expandable valve to self-expandable valve. Self-expandable valve may be preferable because of reduced wall tension and stretching on the annulus. Balloon pre-dilatation followed by complete occlusion of the CX may change the plan to surgical aortic valve replacement, as in this old patient. In cases of valve repair, inferior STEMI occurred due to CX occlusion 24 hours after mitral valve repair. The complete mitral ring compressed the anomalous segment just proximal to the anterior mitral annulus. No PCI succeeded to open the artery. In this case, there was a preoperative dynamic compression of the CX, most probably due to atrial dilatation, and this predicted total occlusion and VTAC after complete mitral valve ring insertion. Medical treatment and ECMO was done since the lesion is undilatable. And in this case, a new myocardial infarction with proximal CX occurred 5 days after mitral and tricuspid valve repair. It was not due to compression. A suture on the anterior part of the tricuspid annuloplasty ring was most probably the cause and was the cause of successful PCI and stenting. In this case of mitral valve repair and CABG, an unexpected tear occurred in the roof of the left atrium and repair was done. Due to appearance of a new wall motion abnormality in the lateral wall in the transesophageal echo, an extra venous graft to the anomalous CX was done. Post-repair transesophageal echo showed a normal left ventricular motion. Early suspicion of the iatrogenic damage to the anomalous artery was the key for complete recovery in this case. It was not annular compression. Regarding prosthetic valves, this is a rare case in which compression of the bioprosthetic mitral valve occurred only 9 years after the surgery. It was documented by Ivus and PCI was done. And in this patient, no previous angiography was done before an urgent aortic valve replacement. Inferior STEMI occurred 12 hours after the operation. Coronary angiography showed occlusion of the CX and PCI was done. The incidence of occlusion is very high when there is double valve replacement. Both aortic and mitral valve prostheses compress the anomalous CX. In this case, OM was grafted. Very early post-operative imaging in the form of coronary angiography is very useful. In the hybrid room, coronary angiography is done post-sternal closure to confirm patency or occlusion of the anomalous CX. Other procedures include osteosecundomy SD closure. In this case, there was a deficient posterior inferior limb, and the anomalous CX was only about 25 millimeters away from the posterior limb. So the plan changed to a less rigid device closure and under the guidance of TE and RCA angiography. The retroaortic segment, while passing near the connection between the mitral and tricuspid annulus, is near to the inferior border of the septum. Remember the rack sign in the four-chamber view. For prevention and precaution procedures, pre-procedural imaging is very important. It defines the proximity from the mitral and tricuspid annulus, calcification at the annular level, retroannular or retrosinus level of the retroaortic segment. Routine pre-angiography is considered by some authors. High clinical suspicion and interpretation is very important, with any evidence of ischemia up to myocardial infarction post-procedure. Mechanism is mostly distortion if lack of symptoms early after surgery, progressive occlusion of a large artery, and PCI done easily. Long-term follow-up with low threshold of anticipation with any symptoms or signs. Undersizing or using less rigid devices is important to afford added protection to the anomalous CX. Technical points in surgery is important. Using incomplete or ringless procedures, anterior bites not too deep or avoided, and avoiding annular enlargement. Avoiding left atrial appendage resection. Some authors suggest mobilizing the anomalous CX to increase the distance from the mitral ring. Bypass grafting with proximal ligation is highly considered when there is segmental wall motion abnormality, severe abnormality, especially if with reduced ejection fraction. When the posterior aortic root enlargement is planned, double valve replacement, or failure of mobilization of the anomalous CX. Ivus has a major role in anomalous CX. It differentiates dynamic compression, yellow arrow, from lesions or spasm. And it may guide PCI to abolish this dynamic compression. Ivus images is very helpful for chamber orientation to the CX. Also, it detects the level of compression and the presence of calcium. So, in our case, there was no rush for stenting this area except after Ivus evaluation. The compression was not severe nor retroannular with absent calcification. If there was a significant plaque rupture or lesion with the compression, drug-coated balloon strategy may be recommended, especially if it is retroannular and calcific after good preparation. So the patient was discharged with anti-ischemic treatment, including high-dose beta blockers. In summary, retroaortic segment of the anomalous CX from the RCA should be under focus with clinical interpretation and possible imaging. This detailed interpretation should include evaluation of the related anatomical structure pathology. Imaging is very important before BCI in this segment, especially with absent long-term studies, and in certain situations, stenting is not advised. And this is the end of the video. Thank you for your attention and waiting for your feedback.